Hi guys, good evening, and you're very welcome to our tutorial on aerosol generating procedures and airway management for COVID-19 patients. We ran this tutorial last night and our platform reached capacity. So due to demand and people contacting us and wanting to sit in on the tutorial, we decided to run it again this evening. So this is not a recorded session. This is live. So I've muted everybody's microphone just before we start. You can probably see that. So I've got a little presentation that we put together here for you last week. We put this together in, I suppose, response to communications that we got from first responders and EMTs who'd been through our training centre, asking specifically, you know, what should we do from a PPE perspective? And we thought one of the biggest risks to first responders and medical staff, in particularly, are aerosol generating procedures, and that might be something that you haven't heard of before. You haven't heard that terminology, that phrase. So we wanted to do a small tutorial for you, talk to you a little bit about that, how you can protect yourself, how, I suppose, dealing with suspected COVID-19 patients or confirmed COVID-19 patients would impact on you as a first responder or as an EMT. Now, last night we had people logged in from all different disciplines. We'd first responders, we'd EMTs, we'd paramedics, we'd advanced paramedics, we'd nurses, we'd some of our colleagues, HCPC registered paramedics from the UK logged into the session last night, which was absolutely fantastic. And we're delighted to welcome everybody here this evening, which is great. So format for it, we've got a bit of a presentation that we put here together for you. I'll work my way through the information and we'll give that to you. And then if you want to ask a question, in the top right hand corner of your screen, there's the option to do chat. So if you type your question into the chat, I'll do my best to answer it for you. We might keep the kind of questions till the end, so I'll get through the material and then I'll go through the chat history with the list of questions. And I'll do my best to answer as many of them as I can. I'll also go through some of the common questions that we got asked on last night's session, and I'll give you those answers just in case people are interested in what was asked yesterday evening. That's pretty much it from an intro perspective. We'll kick on through it. I suppose Dan Davern is my name from any of you guys that I haven't met before or who are new to dealing with us here. My role is Managing Director at DX2, and DX2, you may or may not know, we're a FEC registered training institution since 2010. We teach everything all the way up to EMT. We're also a QQI registered training institution, and we deliver some programs in the QQI space. We're also an NAEMT registered training centre, and we deliver all of those pre-hospital education programs, from pre-hospital trauma life support to emergency paediatric care, geriatric medicine, all those programs that apply to kind of first responders and pre-hospital practitioners. From my perspective, I'm an advanced paramedic. I'm also a HCPC registered paramedic in the UK. I'm a FEC tutor, and I'm one of the faculty members for the Difficult Airway EMS course here in Ireland, which we're the only centre in Ireland who runs that particular course, you know, the Difficult Airway EMS and the Essentials of Airway Management course for responders and practitioners. So that's a little bit about me and what we do. I suppose just to talk about this session here this evening, and sorry guys, you'll see my hand going up. I'm admitting people into the meeting as we go along, for anyone who's still sitting there. So we put this together, I say, last week in response to the questions that have been asked, and actually just 2 days ago, the day before yesterday's podcast, the Pre-Hospital Emergency Care Council and the chair of the Medical Advisory Committee, Dr. David Menzies, published a advisory note or a guidance document to all responders, registered practitioners, recognised institutions, specifically about aerosol generating procedures. And I'm delighted to say that everything we've put together from this point of view for this presentation is echoed in what Dr. Menzies has said. So what we're going to be talking about this evening is actually been validated and I suppose endorsed by FEC and the Medical Advisory Committee. So I'll publish a link to that document in case anybody hasn't seen it. I'll publish a link to that document into our EMT CPC e-learning. If you're an EMT and you want to get some free CPC points, you can register for that. The link is on our Facebook page. Go to DX2 on Facebook. You click into that. There's some free resources and some free online courses for EMTs. I'll also post a link to that on our public Facebook page and our Twitter account. So if you follow us on any of those platforms, you'll be able to see that document. Keep in mind that you as a responder or you as a practitioner, particularly the practitioners, you're privileged to practice by a CPG approved provider. Now, that might be the voluntary organization that you practice with, or the private ambulance service that you work for, or, you know, like myself and many of our faculty members, some who are logged in this evening, work for the statutory services. So you're privileged by those organizations to implement CPGs. And again, keep in mind that you have to be conscious about the guidance that comes from them as well, and indeed your clinical practice guidelines, and you shouldn't step out of those clinical practice guidelines or outside of the guidance from your CPG approved providers, especially now. The other logo you see there is the HPSC, which is the Health Protection Surveillance Committee, and they're our centre, and they're the body who issued guidance on public health and health protection surveillance, and they've issued an awful lot of stuff recently, and that information is changing day to day. So it's a really good resource for information, especially about dealing with COVID-19. Keep in mind that everything we talk about this evening is based on the premise that you're wearing the most appropriate PPE for dealing with these patients. So if you're dealing with a suspected COVID-19 patient or a confirmed COVID-19 patient, you must wear the appropriate PPE for dealing with those patients. Now, the appropriate PPE for dealing with those patients is pretty much the same for all kind of responders, practitioners, and all the CPG providers have adopted that same approach. So it'll be goggles, face mask, apron, gloves. Some might go a bit above that and beyond that, but that's what's recommended from a PPE perspective. And again, you'll take that guidance directly from your CPG approved provider, and making sure that you wear that, because I can't stress that enough, making sure you protect yourself with PPE is really important, especially with what we're going to talk about this evening. Is that okay? Now, again, I don't want to talk too much about, I suppose, coronavirus itself, but because we could be here all night, so let's just touch on it briefly. So, you know, it's a SARS derivative virus. It's been very popular in the news recently. It's all over the media, social media. It's all people are talking about. So it is a virus. It infects through contact with the mucous membranes. There's a significant risk of transmission from droplet formations. Is that okay? And especially what we're going to talk about this evening has the potential to create not an awful lot of droplets, and there's evidence that airborne transmission can happen. So it can be transmitted through the air during aerosol generated procedures. Okay, so that's why we're talking specifically about that sort of stuff this evening. So aerosol generating procedures, you know, term you may not have heard before, or you may not, maybe you have, and you just, I suppose, don't give it a second thought. It's not something we generally have to worry about. The HPSC define aerosol generating procedures as any medical or patient care procedure that results in the production of airborne particles, which can remain in the air, travel through the air, and may cause infection if they're inhaled or get in through the mucous membranes. And again, the risk with these aerosol procedures is the healthcare staff or first responders or frontline staff who might be carrying out these procedures. And that's you guys, and hopefully that's why you're here this evening, to learn a little bit about it and how you can protect yourself. So some of the things that we're going to talk about this evening are procedures that might generate aerosols and droplets, which are the sort of that pathogen or that transmission for COVID-19. We're going to talk a little bit about oxygen delivery. We'll talk a little bit about suctioning. We'll talk about CPR and bag mask ventilation for our APs and HCPC registered paramedics who are joined in with us this evening. We'll talk a little bit about intubation and CPAP. Same for our paramedics who'd be familiar with CPAP. We'll talk a little bit about that. And we'll talk a little bit about nebulization as well. Now, HPSC, you see the little asterisks on the screen there, HPSC don't consider nebulization to be an aerosol generating procedure. We'll just have a little chat about that and see, again, are we taking all the reasonable steps to protect ourselves at that time? So let's talk a little bit about oxygen administration, something that we do an awful lot of as practitioners and maybe even responders. You're kind of getting involved in that. So what we're saying here is, if you have to administer oxygen to patients, sorry, we're still getting people up in there. So, but if you're getting, or you have to administer oxygen to patients, we want you to start at the lowest possible flow rate to achieve that targeted SpO2. So if you're doing SpO2 monitoring or monitoring the perfusion for patients, you're going to try and titrate for adults, particularly your SpO2 to 94 to 98%, for kids, 96 to 98%. And we want to start at the lowest possible flow rate to achieve that. So if patients need oxygen, i.e. if their SpO2 is below 94, and then we need to give them oxygen, we want to start at the lowest possible flow rate to achieve that. And again, a non-rebreather mask is more advisable than a nasal cannula, especially for dealing with suspected or confirmed COVID-19 patients. And again, it's to do with that aerosol production. So if you can use a non-rebreather mask rather than using a nasal cannula, then that's probably the best option to go with. Now, anyone who's come to our Essentials of Airway Management course or the Difficult Airway EMS, so any of our respondents or practitioners who come to that course, we're big fans of using high flow nasal oxygen and apneic oxygenation, especially for dealing with cardiac arrest, respiratory arrest patients. We're big fans of using that. And that's not advisable for dealing with COVID-19 patients. And again, because of that production of aerosol is so high, we're kind of saying, no, we're not using high flow nasal oxygen. It's not advisable at any stage, especially in a pre-hospital environment. So non-rebreather mask is the best option for oxygen administration to patients. Hope that answers that little section. Again, if you've got any questions, try and keep a kind of little record of them, and you can type them into the chat at the end, and I'll do my best to answer as many of them as I can for you throughout the evening. Now, move on to suctioning. And I suppose this is kind of rapid fire going through some of the info here. So again, suctioning procedure that sometimes we have to perform for airway management. And what we're saying here and what the guidance is saying, particularly from Dr. David Menzies' advisory note, and again echoed in what we put together here, is suctioning is not advisable. So avoid the use of suction if at all we can. The portable suction units that we have in a pre-hospital environment, be it electric or manual suctions, aren't closed systems. So again, you're creating a significant amount of aerosols using the device itself, and it kind of vents from an open air perspective. So it's really not advisable to suction unless it's absolutely necessary. And again, the reason for that is because it's not a closed circuit that can produce aerosols. Now, if you do have to suction patients, if you've got a pretty bad airway, pretty soiled airway, and it's going to prevent you from ventilating the patient appropriately, then obviously that's something that you have to do. And we're trying to say avoid it as much as is possible. If you do have to suction a patient, and again, your position for this is going to be really important. So rather than being directly over the patient, try and take a position maybe to the side of the patient where, you're not at risk of, or not as much at risk of, that aerosol affecting you. That being said, if you are doing this procedure, guys, the minimal amount of people within the vicinity for dealing with COVID-19 or suspected COVID-19 patients, minimum amount of people around, and making sure you've got full PPE on, especially if you're undertaking this. But the take-home message from a suctioning perspective is avoid, if at all possible, if you have to do it, with extreme caution, as short as possible, and again, as the minimal amount of people around as is possible. So if you've got patients who've got, mild secretions where it's not really going to affect you managing their airway, then let's just try and manage their airway. But if you've got a really bad airway that you need to suction to manage it, then obviously that's something that we have to do. So hope that clears that one up. Hopefully you'll get something out of that session, guys. But again, if you have any questions, you can fire them up into the chat at the end, and I'll do my best to answer them for you. This is something we got a lot of questions about this last night on the tutorial. So CPR and bag mask ventilations. We had a lot of first responders from first responder groups who logged in yesterday evening, and they asked a few questions about this. So again, I'll try and go through some of those common questions that we had at the end. But let's talk a little bit about it. So, CPR or chest compressions has the potential to produce aerosols from a patient perspective, and ventilations, be it with bag mask ventilations or pocket face masks, again have the potential to generate significant aerosols, again because they're not closed circuits or closed systems. So what the guidance or what the advisory note is saying is that compression only CPR should be done until we can put in place a seal system for ventilation. Now, that might be a bag valve mask for bag mask ventilations, or it might be an extraglottic device like an LMA or an iGel or a King LT or an ET tube, depending on the level of practitioners you've got in place and what's going to happen. That being said, first responders, if you're going to a suspected COVID-19 patient or a confirmed COVID-19 patient and you're required to do CPR, again, PPE is massively important here, guys. Undertaking chest compressions is an aerosol producing procedure. And again, the risk is there from a transmission point of view. So making sure that we take appropriate precautions here is really important. So compression only CPR until we can get a closed circuit or as close to a closed circuit system as we can for managing the airway. Bag mask ventilations, again, if we have to ventilate bag valve mask and bag mask ventilations, it's a two-person job, guys, really here to make sure we've got an adequate seal. And we'll show you some of the grips and the seals in the next slide. And again, anyone who's been to our Essentials of Airway Management or the Difficult Airway EMS course, you would have been through this with us. You would have seen the differences and how those seals are really important. That's so important now for dealing with this patient cohort or this group of patients. The other thing we're saying from an advisory group for our practitioners, so again, compression only CPR is advisable, and then straight to an extraglottic device as soon as practical. So you've got compression only CPR, again, if we can't ventilate the patient in a closed environment, we haven't got two people, we go straight to extraglottic placement. So that's your LMA, second generation LMA, your iGel, your King LT, or indeed in an endotracheal tube if we're going to look from an intubation perspective. The important things about this is if we are going to ventilate the patient, that a viral filter should be used as part of the circuit. I'm going to show you what that is in a minute and show you how it looks in the circuit. But again, it's really important that these things are in place. Here, sorry, I'm just going through the chat. Somebody is not getting any sound. Sound seems to be working okay. It's working okay on our end. So just make sure that you've actually clicked on the audio to be able to do that. So just click on the audio. If you can't, just leave the meeting, join back in. We'll admit you back in, and again, just make sure you click on the audio option to allow audio to come into you. I hope that helps. So yeah, viral filter, guys, really important part of the circuit, especially now to protect us, especially with those suspected and confirmed COVID-19 patients. So we'll talk a little bit about those in a second. Bag mask ventilations, again, if we got to do it, that seal is going to be really important. So again, most of us are used to using a bag valve mask with one person, and we're going with this EC grip, which is this one here. And again, anyone who's been to that course that we teach, you see how this is not really a good device. Our colleagues in anesthetics or anesthetists are really good at doing this. It's what they do all day, every day. They're absolutely fantastic at being able to manage an airway like this. It's fantastic. We don't get as much exposure to it. Therefore, we're not nearly as good as being able to make a seal with this. So again, what we say on that particular course is the EC grip is not great. It's probably the poorest option that we've got. Two-handed technique is obviously far better. And the one in the middle here, this is okay. You see, we're able to push down on the mask and we're able to lift the face a little bit to give us a bit of a seal, but you still do get some air loss. So again, it's not a bad option. It's okay. But the best option here, guys, is what we call the TE grip. Okay. And this is definitely the best option, especially with these patients, if you have to use bag mask ventilations, that you get a good seal. So the TE grip involves you stretching the mask out over the patient's face and then sealing the mask around with your hands. And you can see here that the palm of the hands sit on the side of the mask like this. And now what the practitioner is doing is, while the palms of the hand push down on the mask, they're actually lifting the patient's face and lifting their jaw into the mask. So it's kind of like a trauma jaw thrust for those who be familiar with that procedure. And that's definitely the best option for sealing the mask from a bag mask ventilation perspective. Hope that helps people. And again, if you're not familiar with that techniques, we might try and do a live session with a mannequin and a mask, so you can get a bit more experience or exposure to that. Again, guys who've been through difficult airway EMS or the essentials of airway management will be very familiar with those techniques. This is the airway circuit. So this is what it should look like now. And again, let's start at the very bottom. So you've got your, sorry, I'm jumping. You've got your extraglottic device here, which in this case is an LMA. And again, ideally that should be a second gen. You know, might be an iGel, it might be a King LT, might even be an endotracheal tube if you know we're going through intubation. Might be here from a circuit perspective. You know, if you haven't done supraglottic airways or extraglottic airways, maybe your CFO community, this might just be your BVM mask. Is that okay? Now, here's the important bit. This is the viral filter. Okay, you see there's a color here on this one. This is yellow. There are different types depending on the manufacturer. The important thing about those filters is that they're a bacterial and a viral filter. Again, if you're working for a CPG approved provider, you know, be it a voluntary organization or statutory service or private ambulance service, again, somebody in procurement, if they are getting these in, will make sure that they meet the need or meet the standard, so that they are a bacterial and a viral filter. The most important thing about the viral filters is that they go as close to the patient as possible in the circuit. So directly onto the BVM mask or directly onto the extraglottic device, as you can see here in this case. Apologies for my terrible drawing. Art was never one of my strong points, but I hope the message is coming across to you. So you can see the viral filter has to go as close to the patient in the circuit as is possible. And again, that's really, really, really important, especially now, guys, with these patient cohorts that we're dealing with. The next things you'll see in the circuit, next up here, this is the EtCO2 detector. So again, any of our paramedics or our AP or our nurses or our doctor clients might be using end-tidal CO2 in your circuit. Any of our responders, you might see these guys, or you might see when the paramedics or the APs come, you might see this little device going on, and that's to measure the end-tidal CO2. Again, we'll do a separate session on that for anybody who's interested down the line. And that's what that is. So just so you're familiar with what it is in the circuit. Okay. Next is we've got a BVM extension. That's up here. So you can see the BVM extension, or their catheter mount sometimes as they're called. What that does is that gives us the ability to manage the patient's airway, or manage the BVM itself, from not directly over the patient's head. Is that okay? So we can manage the airway from the side again. The main point of this is it keeps us out of the way from an aerosol production perspective. But the beauty of the airway circuit like this and going straight to an extraglottic device is that it may, especially one that's sealed appropriately, so second generation that seals appropriately in the patient, it gives us as close as possible to a closed circuit as we can. Therefore, aerosols that come back up through the tube actually get into the viral filter, and that's what that's there for. It does its job. Big thing again, guys, if you're disconnecting the circuit, make sure you disconnect above the viral filter. So from here up when you're disconnecting, and again, leaving the rest in place, because again, the filter is there to do that job for us. Is that okay? So that's really important. And then obviously our BVM. Keep in mind that this is an adult BVM. Sorry, somebody jump in. This is an adult BVM. Oh, get rid of that. Oh, this is. So an adult BVM has a volume of 1,500 mils, give or take, depending on the manufacturer. The average tidal volume of an adult is between 500 and 600 mils, now, depending on what book you read. So that means the amount of air that we actually need is between 500 and 600 mils of breath. Yet the volume of this bag is 1,500. So if you are pressing the bag, especially now, and again, you know, guys would have been trained with this if they've done EFR or EMT or paramedic AP, you would have been trained with this. So it's a third of that bag. Is that okay? Now, it's really important here, guys, that we try and keep to that. So we try and get the best tidal volume as is possible, okay? Not only is that providing a better standard of care for the patient, but it's also reducing the amount of aerosol produced. So again, really, really, really important nowadays to making sure that we're keeping that tidal volume. Again, it's one of the big things that we talk about in those courses. You know, overventilation has the potential to have serious negative impact on patients, inhibits venous return, raises intracranial pressure, all that stuff that, you know, is really not good for a patient, especially in cardiac arrest. But particularly now, we want to make sure that if we're using the bag, that we're ventilating at the appropriate rate with the appropriate volume. So literally a third of that bag, 500 to 600 mils. Once you see chest rise, that's enough. That's going to be really important. And keeping your rate, you know, that's going to be really, really, really important now, especially dealing with these cohorts of patients. So I'm just going to get rid of all that. Hope that helps with the airway circuit, guys, and I suppose clarifies a few things, especially if you've read that advisory document already. Hopefully that's been able to answer a few questions that you've had about it, or at least giving you some context or some information about what we're talking about here. Moving on, talk a little bit about nebulizers. So the HPSC says that nebulizers is not classed as an aerosol generating procedure. Okay, what they're saying is that the aerosols produced during nebulization are derived from the medicinal fluid and not, you know, directly from the patient. So that's what HPSC are saying. The advisory note from Dr. Dave Menzies and Medical Advisory Committee is nebulization is not an aerosol generating procedure. If you do have to do it for patients, that you use the nebulizer mask and you try and put a surgical mask over that for patients if they'll tolerate it. So that's coming. Again, we don't really have an awful lot of evidence on nebulization, and, you know, does it produce aerosols, does it not? Does it transmit COVID-19 or does it not? We don't know. The evidence is not there for it. And we can only go on the evidence that is available and what we know so far. And say HPSC are saying at the moment that it's not an aerosol generating procedure. So we kind of have to go with that. Now, that being said, if you're responding to an asthmatic patient, COPD patient, or somebody who is having breathing difficulties where they're wheezing, and you feel the need to give them a medication like salbutamol or Ventolin, same drug, and you're going for a nebulizer, what I'd say to you is maybe consider the patient's inhaler if they have a spacer device. And the Asthma Society of Ireland guys are putting out some great information for, you know, how to deal with asthmatic patients, you know, where there's a risk of COVID-19. They're putting out some really, really, really good stuff, and I'd really advise you to, you know, click into their resources and have a look at those. But again, if you are dealing with a patient where, you know, they've got a wheeze, you need to give them some medication, maybe consider their inhaler with a spacer device, you know, pulling the appropriate volume of puffs from the inhaler into the spacer device and allow them to take the medication that way. Again, it's just a consideration for you that you might think about. But if you do have to give them a nebulizer, again, HPSC are saying it's not an aerosol producing procedure. The advisory from FEC and Dr. Dave Menzies says, you know, if you're going to give them a nebulizer, put a surgical mask over the nebulizer if they'll tolerate it. And again, try and do it in a ventilated area. Again, suspected COVID-19 patients, confirmed COVID-19 patients, making sure you're wearing your appropriate PPE and minimizing the amount of people in the vicinity as best as possible. Hope that answers some questions about that, guys. Hope it's clear, and it, I suppose, clarifies anything that's in there. Intubation, again, for any of our advanced paramedics or our HCPC registered paramedics who are logged in to us this evening, I suppose talk a little bit about this. FEC's advisory document says that intubation should be avoided and a supraglottic airway should be recommended for advanced airway management. International guidelines vary, like the Safe Airway Society in Australia are saying intubation you should go to that to be able to do it safely. And again, some of the guidance and rules around this would be very similar to what we talk about in the difficult airway EMS course. Should be the most experienced practitioner conducting the intubation. Shouldn't ventilate them prior to it. Avoid high flow nasal oxygen or apneic oxygenation. Use a video laryngoscope or a VL. Again, position the patient for optimum first pass success, use the bougie, all the stuff that we talk about that should be common practice from an intubation perspective should maintain. But again, the advisory document, and I can't stress enough, guys, if you're working for a statutory service, private ambulance service, or any CPG approved provider, you have to go with the guidance from your CPG approved provider and the Pre-Hospital Emergency Care Council. That's, you know, what keeps us safe here in Ireland. So what FEC are saying at the minute is intubation is not advisable. Obviously, if your CPG provider and its medical director issue something different, then that's okay. You got to go with those. But that's what the guidance coming out at the moment is. I say it varies internationally. There's varied guidance around this from an intubation perspective. But again, I just wanted to touch on it briefly because we did get some HCPC paramedics and some APs who logged into us yesterday evening. So hope that helps, guys. Hope it answers a few questions on it. Makes it a little bit different. For our paramedics and our APs, again, CPAP, something you might see for those pulmonary edema patients. Because it is an aerosol generating procedure, due to the nature of it, again, anyone who's seen it or used it, you'll be very familiar on why it is pushing that positive pressure air down. The advisory is it's not advisable. Is that okay? Again, I'm trying to think. It's not often that we use CPAP here, and again, I've used it a couple of times in the last couple of years. Not a whole heap, to be totally honest. And again, if we can avoid it, a bit like suction, guys, if it's a procedure we can avoid, then we should avoid it. Again, that's just what the guidance is saying. So we've got a couple of people jumping in who are probably just going to catch the end of the chat and any questions that we have. I suppose just to summarize, so what we talked about this evening, you got to follow the guidance of your CPG approved provider. HPSC, great source of info and guidance. Your PPE, guys, can't stress this enough. Really, really, really important to look after yourself from a PPE perspective and from a hand washing perspective. Again, making sure you got your PPE on long before you meet the suspected or the confirmed COVID patient, and appropriate decontamination procedures after. Again, that should be all laid down for you by your CPG approved provider. If we're going for oxygen delivery, oxygen at a lowest possible flow rate to achieve our SpO2 of 94 to 98 for adults and 96 to 98 for children. One thing I didn't mention that was in the guidance document from FEC was, again, if you're going with a non-rebreather mask and you can put a surgical mask over the non-rebreather mask if the patient will tolerate it. That's something that was in the advisory document. We hadn't thought about in the presentation, but it is there in the advisory document from FEC, so maybe something to think about. Suctioning, as we said, we should avoid if at all possible. Again, unless you need to do it to manage the airway safely, it's something we should be avoiding. Bag mask ventilations and extraglottic, as per the circuit we've shown you. Try not to ventilate the patient until we've got a closed environment, be it with a good seal with that bag mask, bag valve mask for bag mask ventilations, with the viral filter on first, and then maybe your catheter mount, your BVM, if you're going from that point of view. For practitioners, again, straight to extraglottic device as quick as is reasonably practicable for a patient. And again, that's your King LT, your iGel, your LMA, going straight to that device. Again, the importance of that, making sure you've got a good seal so you're inflating it properly. For the iGel, obviously no inflation required. Next is the viral filter in your circuit, then your ETCO2, then your BVM extension / your catheter mount, again, to allow you to position yourself to the side of the patient. Again, if you are ventilating the patient, guys, 500 to 600 mils, again, keeping that appropriate rate, keeping the appropriate volume. That's really, really, really important for these cohorts of patients. As we said, HPSC saying nebulization is okay. Again, I'm of the opinion, let's take the precautions. So again, few as people as possible, making sure we're wearing our PPE. Sorry, questions coming in. Just give me 2 seconds, guys, and then I'll open up to all the questions there for you. I'll open them up on the screen and we can have a chat through them if that's okay. On the NEB, taking your precautions, wearing your PPE, minimizing the amount of people coming in contact, and then decontamination afterwards. again, going to be really important. For our APs and our HCPC paramedics, FEC in Ireland here aren't advocating intubation. As I say, the guidance on that varies internationally. So, have a read of some of the evidence that's out there and that's available. We're saying CPAP should be avoided again, if at all possible, similar to the suction. And again, the last message I want to leave you with really is, please, 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 in everything you do, be very conscious of aerosol generating procedures. These are things we take for granted in normal practice, giving somebody oxygen, running a nebulizer, ventilating a patient from a cardiac arrest point of view, things we take for granted. It's really important, guys, that we're conscious of them now, especially with dealing with suspected and confirmed COVID-19 patients. So that's all I have for you. That's pretty much the same chat that we had last night. I don't think I've said anything different to what we chatted about last night. So any questions that you guys have, if you want to tap them into the chat bar, and I'll try and go through them sequentially, and I'll answer them as they come up on the screen. And again, I'll try and go through some of the common ones that we got last night. Question from Carl's iPad. On non-rebreather mask, when using ETCO2, the surgical mask actually inhibited the patient came around when a surgical mask removed, but increases the risk for the practitioner. So a non-rebreather mask with an ETCO2, so you're talking about a nasal ETCO2, Carl? I'm not really sure what question you're asking there. Yeah, I agree that, a surgical mask over a non-rebreather mask, how is that looking from a perfusion perspective? And again, not really sure, to be honest. You got to have a look and see what the trends are like with your SpO2 when you do that. Again, the evidence for it, again, is not huge. There's not great evidence around, is it safe, is it not safe, or whatever. It is coming in the advisory document from the Pre-Hospital Emergency Care Council, so one worth considering. Again, but if it's affecting perfusion for the patient, if your SpO2 has been affected by it, or patient isn't perfusing properly with it, then yeah, look, you got to make a clinical decision in the best interest of your patient. Again, being cognizant of your own safety too. But again, if you've taken the appropriate measures from a PPE perspective, should be absolutely fine. Hope that answers that one. Anybody else, guys, questions? Please do throw them into the chat, and I'll do my best to answer them. Thinking back on some of the questions that we had, yesterday evening, was around first responders and CPR and PPE and that. And again, I know the National Ambulance Service have kind of directed from a CFO group perspective that they're only sending them to cardiac arrests and suspected choking, that they're not going to, your chest pains and your CVAs, which they had been doing to previously. I got asked, is that likely to change or have you? And the honest answer is, I don't know. That's kind of really down to the National Ambulance Service and what they see as the perceived risks and what's going to happen there. So again, I don't really know. That was the answer to the question that we gave yesterday evening with that. Other questions coming in. What kind of cases are you seeing on the ground? I suppose, look, from a service perspective, the majority of the cases that we're seeing are, suspected COVID-19 cases where patients are presenting with difficulty breathing, high temperature, sore throat, aches and pains. They're the sort of cases that we're seeing. A lot of people are ringing, 999 and 112 looking to see, can they get tested? And that's obviously putting a huge strain on resources for us at the moment. But a lot of the cases that we're seeing are kind of COVID or potential suspected COVID-19 patients. And a lot of those cases, especially ones I've been to, in recent days and weeks, haven't been, grossly unwell. So haven't been patients that will require emergency department treatment. A lot of those cases, might be better off self-isolating at home. So that's the majority of cases that we're seeing at the moment. But keep in mind, all the other cases, your heart attacks, your strokes, your trauma, your other infections, your sepsis and stuff like that, that's not going away. That's all still here as well. So we're really trying to manage the balance between, suspected or potential COVID-19 cases and other cases, and try and give everybody the appropriate level of care that they need while trying to keep us safe too, which is really what we're doing. Another question from somebody: when is the next responder airway course? Really good question. When are the pubs going to be open again? We just don't know, and that's the honest answer to that. Obviously, from our point of view, we're trying to maintain social distancing. We're trying to heed the guidance from public health and making sure that we're doing everything to keep ourselves and in particular in DX2, our faculty safe at those times. So when the next course where we can get people in to do that, I really don't know is the honest answer. As soon as it's safe for us to be able to do that, we will. I hope that answers that question for whoever asked there. Let me see, I get some more questions coming in. From Mick: can you clarify PPE? Good question, Mick. So I suppose PPE will be determined by your CPG approved provider and what they issue to you guys. I know the guidance that's coming from HPSC is goggles that meet a particular EN standard, face mask again that meets a particular standard, apron and gloves. That's the recommended PPE for dealing with suspected or confirmed COVID-19 patients. I know what you'll see in hospital might differ or vary a little bit, and again, they're going off their guidance. But from a pre-hospital perspective, that's the appropriate PPE as is termed at the moment. But again, I'm conscious that different CPG approved providers might issue more PPE over and above that, and if they do, then that's absolutely fine. So I hope that answers that question. Next one that's coming up: are you treating all respiratory cases as COVID-19? Good question, Mick. Thank you again. Just two in a row. You're flying. Are we treating all suspected respiratory cases as COVID-19? Again, the guidance for us from an ambulance point of view, we're working off an algorithm that's version 5.6. And obviously there are certain criteria, certain markers for suspecting COVID-19. Hospitals, again, depending on the hospital you go to, a lot of them are treating respiratory cases as potential COVID-19 cases. And that, kind of makes sense if the patient meets the criteria. Like if they've got shortness of breath, they've had, high temperature or some of the other associated symptoms, then yeah, it might be prudent to do that. You might see patients who are kind of over triaged, if you like, or treated as COVID-19 or potential COVID-19 patients, with shortness of breath or respiratory problems or issues. So yeah, you probably will see kind of like an over precaution for dealing with those patients, to be honest with you. And the reason for that is when you look at the evidence of it, an awful lot of patients who are positive for COVID-19 might be asymptomatic or might have kind of atypical symptoms, if you like. Because again, we've seen that in the research in South Korea, where a lot of the patients from that kind of 18 to 40 age bracket, a lot of those patients were completely asymptomatic, even though they were positive for the virus. So yeah, I think you're probably going to see an awful lot of respiratory cases that are treated as potential COVID-19, or the majority of them. And again, that's the kind of main reason for that. So I hope that helps and answers that question for you. From Dean: should you take precautions when giving inhalation medication? So yeah, if you're using nebulizers like we talked about, although it's not an aerosol generating procedure as determined by HPSC, again, I would still be taking the precautions. If you suspect COVID-19 or there's a potential for COVID-19, then yeah, I think taking precautions is not a bad thing, and it should be good in this environment. Similarly, if guys are using inhalers, try and advocate the use of a spacer device, which that should be happening anyway. So that's something we should do. But yeah, with inhalation medications, yeah, let's take some precautions. There's no harm in taking the precautions, I don't think, and it's probably something that is advisable. Next one from Sinead: and neb not indicated as an aerosol seems crazy. Just wondering, unless the patient is asthmatic COPD and have ventilator prescribed for them, is it difficult to assume that the neb is required if there's fluid on their lungs from COVID-19? Yeah, okay, interesting question, Sinead. So yeah, nebulizers, like salbutamol or Astrovent, really used for wheezing patients. So patients who have a really diffuse bronchospasm or a wheeze. For patients who have fluid there or a pneumonia, you know, there might be an associated wheeze higher up, but a lot of the time those patients have kind of crackles because of that fluid in there. So you'll find that, you know, the salbutamol or the inhalation medications really won't be beneficial to them. So that's really going to be for the practitioners to make sure they do an appropriate patient assessment. They assess what's going on and they treat the symptoms that are appropriate, i.e., you know, is it bronchospasm? Is it a potential pneumonia where, you know, the salbutamol mightn't have much benefit to them initially, might have a little bit depending if they got an associated bronchospasm. So, yeah, difficult. Hope that answers that one for you. Dean, example, Pentrox or Entonox. I'm just going to go back to your last question, Dean, so I'll make sure I can get the one you want. Should you take precautions when giving Pentrox or Entonox? Yeah, absolutely. So again, if you're giving inhalation medications like Pentrox or Entonox where you're dealing with a suspected COVID-19 patient, then yeah, absolutely. You know, full PPE, minimizing the amount of people that's around, them trying to avoid it in an enclosed space, you know, like the back of an ambulance, just as is normal with any of those medications anyway. But again, there's only so much you can do in these particular options. You know, if you do have pain management, you know, have a look at your alternatives for pain management here. So that might be, you know, requesting ALS for IV pain management, or having a look to see what other options we have from that perspective, you know. And again, it's not that we're depriving care to patients, because that's really important, guys. You've got to act within your CPGs and act within your guidance. We have to manage our patients in an appropriate way, but at the same time here, we've got to be taking precautions and making sure that we do everything we can to look after ourselves. So not thinking outside the box, but thinking what other alternative options have I got here might be something that's worth considering. That being said, if we need to manage the patient with methoxyflurane or Entonox, then that's something we have to do. But again, making sure we take the appropriate precautions. Elaine, hi, I work with private. Should we be wearing PPE with all our patients, even if we don't know if they have the virus? You know, that's a really good question, Elaine. And I know a couple of things that we have to be conscious of here. There is a worldwide shortage on PPE for dealing with this, so it's going to be really hard to keep up with that demand. Look, in an ideal world, considering that we have a global pandemic, yeah, absolutely, it would be brilliant to wear clean PPE for every single case that we go to and every single patient that we go to. Again, that's probably not going to be practical, you know, because there is a global shortage with this sort of stuff. It's really not going to be practical. I think what's really important here, you know, is getting information from the initial call that comes in, or the initial turnout information that comes in. You know, what are all the symptoms? Are we at a potential risk from a virus perspective here? You know, if you're doing a pickup from you know, if you're working with the privates and you're picking up from a facility, you know, getting a handover in a clean environment from somebody before you go and meet the patient, and then making the determination if it's, you know, if they are potential COVID-19 or not, and then taking the precautions. But I think, you know, taking the time to get that information beforehand to make that decision from a PPE perspective is going to be really important. And again, your CPG approved provider should provide you with guidance around this sort of stuff, which I know is kind of not really answering your question, but it's the best I've got at the moment, unfortunately. Hope that helps. From Katie, are all cardiac arrest patients to be treated as suspected COVID-19 until it's proved otherwise with full PPE? Again, really good question, Katie. Very hard to give you an answer. That will be determined by your CPG approved provider. Again, in an ideal world, yes, we should be taking appropriate precautions with all patients that have the potential to be COVID-19 patients, suspected, or definitely with confirmed COVID-19 patients, but with suspected ones. Again, it comes back to how reasonably practical it is to do that with, you know, the levels of PPE stock that we've got and the information that we get in. But yeah, I think it's probably not a bad idea to I suppose take cardiac arrests as potential cases, and again, limit the amount of interaction that we can get, limit the amount of people involved. If you are in like one of the statutory services or privates where you've got access to Lucas, again, trying to utilize that device as early as possible. to reduce the risk and still provide the optimum standard of care for the patient is going to be really important. So again, hope that helps with that. Inhalation medications include Pentrox. Yeah, I think I've got that one. Would you take similar precautions for sublingual medications like GTN? Good question from Cahill. Again, if you suspect COVID-19 with a patient, even though, let's say, the administration of GTN, not classed as an aerosol generating procedure from a patient perspective, but if you are dealing with COVID-19 patients, suspected or confirmed, then appropriate precautions should be taken all the time, regardless of procedure. So, and what I mean by that, I mean appropriate PPE, limiting the number of people in the vicinity or the environment, and again, decontamination procedures there afterwards. So yeah, absolutely. I think if you are putting a mask on a patient, be it a non-rebreather or a surgical mask, again, lifting for the GTN spray, positioning yourself to the side of the patient, and then placing the mask back down. I think that's probably a good approach, and really good question. We didn't get that one last night, so thanks for that. From somebody else, would you be looking for similar breathing sounds as those associated with pneumonia when auscultating the lungs with a suspected COVID-19 patient? Good question. So, COVID-19 tends to cause a pneumonia. That's kind of what it tends to cause. So you tend to get that fluid build up in the base of the lungs. So yeah, it's not like we're seeing new symptoms here for COVID-19. The virus doesn't produce any new sort of symptoms or what have you. They're the symptoms that you're going to come across. So yeah, it'll be kind of similar enough breath sounds from an auscultation point of view. Hope that answers that one. Elaine, well then, should we wear masks with them all? I'm going to go back to your last question, Elaine, just to see what it was. Sorry now. What could approach? Should we wear PPE with all our patients, even if we don't know that they have the virus? Should we wear masks with them all? Yeah, look, and again, I think that comes down to the guidance that's going to come from your CPG approved provider, if they've got the mask stocks. And again, global shortage of PPE here. And again, I think you need to make a clinical judgment or a decision based on what you're going to. If the patient is not suspected COVID-19 or not at risk, would you take precautions? Yeah, look, I think you could. And again, I think you got to be conscious from, what's reasonably practicable here. And, I would hate for you to say, yeah, look, wear masks for all patients. And then, you get to the day where you run out of stock of masks and you're going to a patient who might be, and you don't have that stock. So again, I think you need to make, informed decisions based on the patients that you're going to and the information that you get. Again, I know it's not a great answer, but it's the best one I've got for you right now, unfortunately. From the next one, from a CFO point of view, if we attend a patient that turns out to be suspected COVID, should we automatically move into self-isolation? Good question. So if you attend a cardiac arrest as part of a CFO group, and that patient turns out to be suspected or confirmed COVID, then you're going to get a call from public health early on. So what I would say to you is, from your CFO group perspective, I'd touch base with your coordinator who can speak to one of the community engagement officers, like Donald or Jer or one of the guys who does that, and they can give you guidance on what should be happening here. Again, I'll take that back. I'll try and speak to one of the community engagement officers and see, can they issue you with some guidance on what to do if you've attended a cardiac arrest where the crew suspects COVID-19 or what turns out to be a confirmed COVID-19 case. What will happen there will be contact tracing. So, if you go to an arrest that's transported to the hospital, it's suspected or confirmed COVID-19, the ambulance crew will obviously go through contact tracing, and then you will come up as part of that contact trace, and public health will make contact with you from that perspective to inform you what to do in those occasions. But I will speak to the community engagement officers and try and get you a kind of guidance thing sent out on what to do in those cases. So again, I hope that one helps. In terms of PPE, is there anywhere I can reference in terms of removing PPE and disposing of it safely, or even any tips you've picked up along the way? Yeah, really good question. So the National Ambulance Service actually produced a video for donning and doffing of PPE, which is available on YouTube. So what I'll do is I'll grab the link for it, and I'll throw it up onto our Facebook and our Twitter account, so you guys can access that. Really, really good, done by Lawrence Kenna, one of the education and competency officers in the National Ambulance Service. Really, really, really good. So I'll get that link for you and I'll throw it up there. Hope that answers that. Katie, with Pentrox for COVID-19 patient, will be an issue with respiratory depression as a contraindication? Would it only apply with serious respiratory illnesses? Not Fred, no, sorry, no problem. I think I get what you're asking, Katie. So, you know, if you've got a patient who's got COVID-19, would they have, you know, respiratory depression, and therefore would that make it a contraindication for the administration of Pentrox? It really depends, to be honest with you. So again, if you're going to be giving somebody with suspected or confirmed COVID-19 pain management like methoxyflurane, it's probably going to be trauma related. So again, I think you have to make that decision depending on the condition of the patient. Again, a lot of patients who contract COVID-19, a lot of them are asymptomatic, so they don't produce any symptoms whatsoever. Some will get very mild symptoms, mild to moderate symptoms, and only a small cohort will get really severe symptoms where they'll have, you know, significant respiratory problems. So again, I don't think that it's, you know, somebody having suspected COVID-19 or confirmed COVID-19 is going to make them contraindications for methoxyflurane. I think it'll really depend on the symptoms that they present with. So I wouldn't treat them, you know, in any different way just because they have COVID-19 from pain management point of view. I wouldn't say that they're completely excluded from getting methoxyflurane for that reason. I hope that answers that question for you. If it didn't, just throw back into the chat there, and I'll try my best to address that for you. Any more questions, guys? We're just coming up to 55 minutes, which is probably around the same time that we ran yesterday evening. Hope that helps. Is there any more questions if you want to throw them into the chat now? I don't see any. And again, a lot of the questions that were asked tonight were asked last night. Not really a whole heap more on the list that we got asked yesterday evening that we haven't spoke about tonight. No more questions coming in there, guys. One of our faculty members, you know, mentioned to me earlier on when we were talking about this, about, you know, the use of OPAs and NPAs, particularly, you know, for dealing with suspected or confirmed COVID-19 patients, how if you haven't got an extra glottic device that these might be beneficial for insertion. And again, that's a really, really good point. And we might do a small thing on that and throw it up from a video perspective that can help you guys. And again, we'll publish all that publicly. Just so you guys know, we are recording the session this evening. Again, we just do a couple of edits to make sure it looks okay, and we'll release the video for anybody who wasn't able to log in either yesterday or this evening. And again, give people an opportunity to go back over the stuff. And there's no more questions that are coming in. So from my point of view, guys, listen, thanks for logging in, and the guys who logged into us yesterday, thanks for logging in and listening to us. I hope you've got something from the session. Again, important take-home messages is keep yourself safe at all times, especially during aerosol production procedures. We might do some more sessions, you know, especially as the emergency goes on. If there's things that people are really struggling with or want some info or guidance on, we'll do a couple of tutorials if we can. Other than that, listen, thanks a lot for logging in, and hopefully we'll see you in DX2 in the future in some of our programs. So have a good evening, guys. Good night.